Today we're going to talk about the evaluation of cardiomyopathies, a very important topic. In fact, you could say any first presentation of heart failure is a cardiomyopathy until you line up what the heck is the diagnosis. So in a way, this is cardiomyopathy / heart failure, but this is more emphasizing not the full hemodynamic and how you treat patients that we do in other talks. This is more emphasizing etiology, trying to line up what is the cause of the heart failure. So as a general classification, we tend to say dilated cardiomyopathies, which is a big bad heart, hypertrophic, which is a thickened heart, and infiltrative restrictive, which is this kind of mixed bag of diseases that in some way infiltrate or affect the myocardium, where there can be a long list, but we're going to concentrate on the 3 or so most common ones that we see in practice. And then there's others, because there's kind of funny classifications of cases of patients that you cannot necessarily put a diagnosis. For example, AIDS affecting the heart, so things like that they fall in some sort of a mixed bag. So in echocardiography, of course, our biggest, most important role is defining that we're dealing with a big heart with a bad EF, dilated cardiomyopathy, a hypertrophic type, something that suggests restrictive, and then in some of the others, sometimes we can estimate or suggest an etiology. The most common thing in the echo lab that we can do is try to distinguish ischemic versus non-ischemic. And even that, without a stress echo, can be hard. Because with a resting echo, a dilated cardiomyopathy could be ischemic. A dilated cardiomyopathy that has an akinetic inferior wall could still be non-ischemic. So obviously, if you have a blown out apex with a thin apex and a history of an acute MI and an EKG that is, then you have a diagnosis. But usually you have to kind of put things together because even just with an echo alone, the presence of wall motion abnormalities, regional abnormalities, points to ischemic, but it's not 100%. The absence points to non-ischemic, but it's not 100%. So the most important thing with echo, of course, is we assess the severity of the entity in terms of EF and in terms of diastolic dysfunction, in terms of PA pressures, cardiac output, all the hemodynamics, and try to give indices for prognosis. But when we talk about dilated cardiomyopathies, frequently they all look alike. Now, if you have a heart like this that is dilated, poorly contractile, but the wall thickness is nicely preserved, that in itself points more to non-ischemic. Now, it still could be hibernation. We've seen hearts that are very ischemic and hibernating, and they kind of look like this. So again, these are, you make a statistical call based on these things, and clearly having an EKG around to look at and a clinical history can be very helpful, because many different etiologies will look like this. And of course, you have the idiopathics, the familial, the alcoholics, postpartum, myocarditis, acute and chronic, different kinds of infectious diseases, as shown here, that can involve the heart. Acute changes in EF are frequently seen with sepsis and also people, renal patients in and out of dialysis. So the common situations where we see real shifts in EF are sepsis, renal patients, related to dialysis, and then, of course, acute MI that comes in that gets stented and gets better, Takotsubo that gets better, or acute myocarditis that gets better. But in the acute setting, there are not that many conditions that within a week are going to get better. Most of the cardiomyopathies, they're going to get better. They get better over 6 months, not over a week. Now, there is a group of dilated that do have features that tend to be a lot more specific, and is this entity of non-compaction, which is, of course, a congenital condition. People are born with the genes for this, and is this ventricle that, in addition to being somewhat dilated, although they don't really get very big, and having a low EF, they have all these little areas of non-compaction. And he has been called spongy transformation of the myocardium, which resembles the fetal myocardium. Coarse trabeculations, deep recesses, as you can see here. 2 layers of endocardium, twice as thick as the epicardium. And if you see 45% or more of the LV endocardium that is non-compacted, meaning not the 45% doesn't mean global like this, means like this. So in this case, you have a lot of endocardium that is non-compacted. And these are different examples. This is another example, not as dramatic, not well seen in parasternal views, but nicely seen in the epicals, and you can see these recesses, and there's a lot more than 45% involvement here. However, the basilar segments are relatively preserved. And this is the way this particular patient looks. If you do an apical short axis at this level, then you can appreciate very nicely all of these recesses. This one, again, this is a different one. So again, bad hearts. We see a lot of this in the echo lab every day. We saw a bunch of them this morning. So, but it's a 45-year-old, acute heart failure, and it's not until you get that then you start thinking, okay, this may be AIDS cardiomyopathy. So I mean, frequently these conditions need a lot more help from clinical laboratory findings. And this particular patient had been training for 5 years, and he was receiving intensive medications, and then eventually he went into heart failure. And it's interesting, it's a low incidence. It comes in varying degrees of LV dysfunction. If you get it, it's a marker for high mortality. And there are all kinds of mechanisms, from infection to immunity to deficiencies, even treatment with some of the new drugs. So the hypotheses for what causes this are all over the place. And my suspicion is that we're seeing less of it. At least in the echo lab where everything passes by, I think we're seeing less of this as we saw 10 years ago. So it could be that a lot of the new drugs that are keeping people healthier are also reducing the incidence of this particular entity. I'm not going to talk a lot about hypertrophic because Dr. Naga has a whole hour for himself on hypertrophic cardiomyopathy. However, I'm going to just touch bases on, again, reviewing that there's a lot more than asymmetric septal hypertrophy, which of course is the most common one. But some patients may be concentric, and they may be more tricky because they look like a concentric LVH, and yet they have HCM. The apical hypertrophic is the one I'm going to spend a little bit more time on because it's very important that we make an accurate diagnosis given the EKG of these patients. Interestingly, the Japanese version has a worse outcome than the American version. The American variety of apical hypertrophic cardiomyopathy tends to be fairly benign, and patients do well over decades. Mid-ventricular is extremely rare, and then asymmetric free wall is even the most rare of all. Now remember that there is a differential diagnosis for HCM. Sigmoid septum of the elderly is the one common one that we see. Amyloidosis, we're going to talk more about it. The athlete's heart, I think, has a topic of its own. And again, if ever in doubt about that, which I don't think there's too many times that you're in doubt, this athlete heart don't have any diastolic dysfunction, for example. They're perfectly normal diastole, whereas hypertrophic cardiomyopathy always would have some form of diastolic dysfunction. But if you had any doubt, with 2 months of no exercise, the whole thing goes away. The most important one is secondary LVH from hypertension. But then they have this list of weird diseases that we don't see every day, except for this one. This is just an issue with the echo, appearance by echo. But you have these diseases that they can mimic asymmetric hypertrophic cardiomyopathy. So in a hypertrophic cardiomyopathy clinic, and Dr. Naga will spend more time probably talking about this, you probably have to at least think about them and maybe do a quick family history and maybe some genetic testing if you're concerned with them. Sarcomas, melanomas can infiltrate the myocardium in such a way that they can increase the thickness of the wall. And kind of, in your first look, it may look like HCM. That's the only reason why we mention it here. But the texture is different, and once you spend a little bit more time through the echo, most of the time you can tell that it's an infiltration and not muscle. So I want to spend a little bit more time in, of course, we know about SAM and no SAM. I don't want to spend too much time on this one because Sharif is going to talk a lot about it. Apical ACM is the one that we're going to talk a little bit more about it because this is a beautiful case. You can see the whole apex with myocardial hypertrophy, and the LV angiogram have this very classic, looks like a spade in a card, in a playing card, where you have this apical trapping with a thin area of dye in it, very high pressure. If you put a catheter here, you might get pressures of 300 or 400 compared to here. And that's why they can get, with exertion, they can get apical infarcts. But echo often misses that. It's a diagnosis that is often missed by echo. This is another case. You can see very nicely the apical trapping. And contrast is extremely helpful. So this is one situation where the contrast is very, very helpful because in apical views, the attenuation of the myocardium here can drop out the echoes, and you may go by the study and totally miss it. So you need some clues so you can get some contrast uninjected. Otherwise, patient will be missed. This is a big clue. You have an EKG like this. If it's not ischemic heart disease, it's likely to be apical hypertrophic cardiomyopathy. So, and that's why it's important, because a patient with that EKG can buy themselves a ticket to any hospital in the country if they show up with chest pain. You know, who wouldn't put that patient in, right? So it's very important to clarify the diagnosis. So, because they can have a typical chest pain like anyone else, and they show up into an ER. They're going to, if you're a homeless and you have this, hey, you're blessed. You can sleep in several hospitals around the city. You can make your rounds and be admitted for a night or two. Now, a couple of other things you can do. Contrast, we already mentioned. Notice with the contrast that the tip of the apex, the little tip of the apex is akinetic. Very nice. It shows you, the contrast shows you very nicely how these people have such a high pressure here that they can develop apical infarcts with thinning of that region and akinesis. Color can help you sometimes because you can, again, the color can emphasize the trapping at the apex. So, without color, without contrast, this patient might have gone by and been missed. So color within the cavity can help you pick up this area of apical trapping. Contrast is just, superb for this. And the other very important view for the sonographers here is an apical short axis. If you get in the habit of going down to the apex and trying to get a short axis very close to the apex, you may not miss the diagnosis and might not even need contrast. Because as you can see very nicely, there's very little cavity left, and in systole, it's gone. So this is a classic short axis view at the apex of apical hypertrophic cardiomyopathy. So that's why I wanted to spend a little bit more time on this, because I know Sharif probably will spend most of his time talking about the traditional ACM. So that takes us to infiltrative, restrictive, okay? So there are a bunch of them, but we're going to spend time mostly on amyloid, sarcoid, and hemochromatosis, which are the three most likely for us to see in a practice. The others become a lot more unusual. And this is a slide that Dipan might even show again, just simply showing that these diseases have bad prognoses, even worse than traditional dilated cardiomyopathy. With all the good stuff we can do for people with non-ischemic cardiomyopathy in terms of drugs and whatnot, the survival of those patients are way ahead, better than any one of these. So you can see here idiopathic cardiomyopathy, then we can see here sarcoid, and we can see here amyloid and hemochromatosis. By the time they present with severe symptoms and the diagnosis is made by someone, often they're so advanced that the prognosis is not good. And of course, all three diseases have therapy. At one time, we always said this one is a kiss of death, but even amyloidosis now, there are being improvements made on therapy. So the earliest we can diagnose them and pick them up, the sooner we can initiate some form of therapy and hopefully change prognosis. With sarcoid, for example, most sarcoid cardiomyopathies are in patients already known to have sarcoid. But if you make a diagnosis of cardiac involvement, that steps up the level of aggressiveness which they're going to manage the sarcoid. At times, somebody may present with cardiac involvement alone, and the diagnosis starts at the heart. It can happen. We all have had all cases. It's more likely to happen through the CMR, as Dipan will show later. But most of the time, the patient is known to have sarcoid, and then the echo is being done for looking whether they have a cardiac involvement. So the earlier we can detect these things, the better chance we have of impacting the prognosis. So this is a typical amyloid. Looks like a renal patient with a lot of LVH, a lot of glistening of the myocardium, which you see it beautifully in people with end-stage renal disease. Bilateral enlargement, reasonable EF, small cavities. Now, the EF is very variable depending on the stages of the disease. The diastolic dysfunction is also variable depending on stages of the disease. Ideally, what's best for a patient is to pick them up with a normal EF and stage 1 diastolic dysfunction, i.e. impaired relaxation, but reasonably normal filling pressures. By the time you pick them up with high filling pressures, pseudo-normal patterns, stage 2 or 3, they are much more advanced, and prognosis rapidly worsens. So these are the key things that we have to keep our eyes on. Increased wall thickness, small cavity, bilateral enlargement, diastolic dysfunction, and here comes one thing that we all depend on. For all the so-called hypertrophy that we see, the QRS voltage doesn't parallel that. So if they have low QRS voltage, that's really good. But even if they have kind of normal looking QRS voltage, you should be suspicious. Because a ventricle that has that much hypertrophy should have very, very nice, big, tall airways. So it's the EKG, when it comes to play with all of these, that makes a big, and frequently we make comments in our reports, consider amyloidosis, particularly if QRS voltage is, is low or whatever. Because that's the final thing we can use as clinicians with echo to establish a diagnosis, at least a presumed diagnosis. You're going to hear about more specific things in the CMR lab. Here we're privileged to have an excellent CMR, so obviously the echo report frequently says recommend cardiac MRI. But you may be in practice in a community later on that won't have that. So you're going to have to make the best you can then with the tools you have. Now, I want to show this because in the amyloid, now there is data, and by the way, you can see that. You can see that. If I play this here, you can see this apex is contracting a heck of a lot better than this basilar segment. So even with the eye, we can see that frequently these people have better motion at the apex than at the base. So now that we have fancy strain, it shows it very nicely. So these are the apical segments, these are basilar segments, and this is the histogram that shows better strain at the apex. And of course, when you put it together in a bullseye, then you have higher values of strain in apical regions, much lower values at the base. And you say, aha! So if you're taking the echo board and they show you a ventricle that is thick and a bullseye like that, and one of the multiple choice questions is amyloid, click on it, okay? That's what they want you to do. However, this is not specific for amyloid, okay? Look at this, beautiful aortic stenosis. Classic. Look at the velocity here. Way up, okay? Classic AS. Should we be doing a biopsy to establish amyloid? Nah. So, in concentric LVH, you can get a similar pattern where the apex is more preserved on the base. Okay? Now, by the time you get this level of diastolic dysfunction, as I said earlier, with type 2 or type 3, look at the relaxation parameters by tissue Doppler, very, very poor. Even though EF kind of looks okay, this patient is in trouble. This is a patient you would like to have picked up, but this is the worst. This was actually a very tragic case. This was 10 years ago. 10 years ago. I was rounding in a weekend, and we were consulted for this 50-year-old woman in the Foundling ICU who was very, very sick. She had just arrived, very sick, and she was in FICU because there were no beds in CCU. She had been seeing cardiologists for over a year. She has gone to 3 different cardiologists. She had had nuclear stress, echoes, cath, normal coronaries, all of this stuff, no diagnosis. And by the time she showed up, she showed that. So you can imagine what her prognosis was going to be like and exactly what it was. She ended up in hospice. By the time they get like this, the game is over. The game is over. There's nothing you can do. Look at her cardiac output, her TVIs are extremely low, very poor cardiac output, just very bad. And of course, these are some of the markers that have been reported for prognosis, very high BMPs, high troponin, and then of course, the echo findings of restricted mitral inflow, low EF, RV involvement, RV dysfunction, and all those things point towards more advanced disease. All right. So, man, what do you think? What do you think this echo shows? Just in 2D alone. What do you see here? Is this a normal echo?
Yeah, sound function might be mildly depressed.
Okay, so what EF would you want to give us an estimate on?
50.
Okay, so around 50? Okay, would you accept 48?
Yeah, sure.
Would you accept 46? Would you accept 52? Yeah, it's in that high 40s, low 50 range. Certainly not 100, not pristine normal. Okay. Okay, and overall, there's kind of like a general mild hypokinesis. Again, we see a lot of these echoes, right? So there's nothing here that points out to any specific diagnosis. This could be a guy with multivessel CAD and global ischemia. This could be a septic guy. This could be many things. Okay, now, what do you see? So you say that there's restrictive feeling here, okay? But look at this E prime is about 12 or more. However, this TR velocity is about, is a gradient of 48. So PA pressures are 48 plus the RA. Pulmonary veins. Now remember, we see more than an echo in a screen when we do an echo. So what else is in this screen that may help you? No. What else do we see in all 4 panels here besides echo pictures? EKG. What does EKG shows? Very long PR. In fact, so long that this is not an E wave, it's an A wave. So actually, this is not restrictive filling. It's just a big A wave here. Very long PR interval, okay? So we have very long PR interval. I have no idea what the filling pressures are. This is one where you say, I don't know. This is not an E prime, this is an A prime, because it's a big, it's an A. Pulmonary veins look okay, and PA pressures ain't okay. So this could be vascular pulmonary hypertension with normal filling pressures. I mean, here you need some more help. But what condition gives you a lowish EF with a long PR interval? Sarcoid, yeah. So this is a patient with sarcoid, of course. There we go. All right. So this is published in 2006. These are the guidelines from the Japanese Ministry of Health and Welfare. You can Google them and copy and paste them, which is what I did. And of course, diagnosis is histologic, right? I mean, that's the bottom line is histology. But very rarely are we going to be doing biopsies of the heart for this. Our non-invasive biopsy now is the CMR. So, since again, not everybody has CMR, they came up with this type of recommendations. In patients with known extracardiac sarcoid, okay, known extracardiac sarcoid, which is, as I said earlier, the majority of patients that come in. Cardiac involvement is suspected when one or more of items B through E are present, okay? So, when item A, in other words, they want to have an EKG abnormality, when item A, which is pure EKG, and one or more of these other ones are present. So item A is EKG. So you start by having EKG that is not pristine normal. Basically, right bundles, left axis deviations, some type of AV block, premature contractions or VT, abnormal Q waves, sort of pseudo-infarcts, ST changes, prolonged PR is involved in the AV block. So it's not a completely normal EKG. So in a way, EKG can be a decent screener. Then with echo, either abnormal wall motion, some EF changes, regional thinning, dilation of the left ventricle. So again, kind of non-specific findings, but in the presence of a known sarcoid, it should suspect in cardiac involvement, and they get perfusion defects, non-CAD perfusion defects. And of course, if you do hemodynamics, then they may have low cardiac output, they may have higher pressures, and so on. So basically, it's either a structural or a hemodynamic involvement that you see in the echo, all of which are non-specific. So that's why they say, okay, if you have a non-sarcoid and you have an EKG that you flunk, and you have one of those other findings, until proven otherwise, you have a cardiac involvement. Okay? In our case here, it would be a nice sentence saying recommend CMR, because now with CMR we can get more specific findings. All right, what about this one? Doesn't look like a healthy guy, right? So we have biventricular failure, biatrial enlargement, lousy EF on both ventricles. Okay, so what else do we have? And the guy's sick, right? He has all the findings. We see these people, again, not uncommonly, right? They show up in the echo lab, in the clinics. How bad is this TR? Anybody? Who wants to say how bad this TR is? C, right. You don't need a Doppler, right? Those valves are going like, hey, how are you? I'm doing okay. Feeling a little tired today. And of course, because it's such a low velocity, it's like having a common atrium ventricle, you practically don't get anything. Yeah, this is wide open TR. Impossible to give a PA pressure, right? Highly restrictive feeling, right? PR, interesting PR, goes whoom and disappears. So you have equalization of PA diastolic and RV diastolic pressures and very dilated IVC. So obviously very sick fellow. But we still don't know what the heck is wrong with him. Okay? We have no idea what's wrong with him. Yeah, I think we already said that, right? Not healthy. PA pressures, we cannot tell. No way we can tell PA pressures because the TR is impossible. The radial pressure is so high that there's just no way. We know they're high, but we have no idea how high. Okay? So what's the diagnosis? What test would you do? If you're going to do any other test, again, don't tell me a CMR. Okay? Sorry, that's not allowed. Many of you are going to practice in places you may not have a CMR. So what would be the next step you would get? Come on, Jeff. You're a clinician. Put your clinician hat. What test would you order? Which we should be ordering in every new onset cardiomyopathy heart failure that shows up in the clinic. By the way, the test I'm asking you for, should be ordered routinely in any new onset heart failure patient that comes in with a bad heart that looks non-ischemic. I mean, if the guy had an acute MI, and you know that, you don't bother with it. But this should, because we should not miss these patients. Huh? What?
Based on the current pattern, it seems to be ferritin.
Ferritin. Absolutely. Yes. Yes. It's a shame to miss a diagnosis so easy to make. So I think in the algorithm of order sets for a new onset heart failure, which is clearly in your mind is not ischemic, this should always be part of it. Because it's a shame to miss that diagnosis. Okay? Yeah. Again, this is the very end stage. By then, you may pull as much iron you want. It's unlikely this guy's going to get better. You would like to pick them up a little earlier than that. But
so I'm going to carry forward from what Dr. Q already talked to you about. And so, I think the first thing we need to think about when we're looking at patients with cardiomyopathy and with heart failure is really to say, is this due to, heart failure with reduced ejection fraction or heart failure with preserved ejection fraction? And obviously, the first line test that you're going to utilize is echocardiography. And I think this important distinction is key because what we know today is that most of our randomized clinical trials have studied this patient population. This is a population that's been demonstrated to have efficacious therapies. Unlike the heart failure with reduced ejection or preserved ejection fraction or HFpEF, which is really a diagnosis of exclusion, and it's one which currently, I don't think we have much in the way of robust efficacious therapies available. And then there's this group in the middle, which is called heart failure or HFpEF with borderline EF, and that's when the EF is between 40 and 50. And I think as Dr. Q very nicely pointed out, your initial evaluation is going to start out with echocardiography, and it gives you quite a bit of information. But one of the things we know is that there are times when the echo may be suboptimal, and simply for assessment of LV function, there's a role for CMR. And if you look at the heart failure guidelines, it gives it a class 2A indication, just simply to assess LV function when the echo is inadequate. The other important distinction, I think, is whether it's due to ischemic etiology, that is significant coronary disease, or whether it's due to a non-ischemic etiology. And the question I'll pose to you here, obviously, is we can take the patient to the cath lab, and we can do a heart catheterization and determine if there's significant obstructive disease or not. Patient, the example on the left here, significant coronary disease. The patient on the right here is somebody who has no significant coronary disease. And I know our angiographers like to, kind of tout their skills and say, die, don't lie. So, I think certainly when you're trying to distinguish between these two, angiography has an important role, but oftentimes you may also get this picture where it's a mixed picture, where there's coronary disease, but the level of LV dysfunction is really out of proportion to the extent of coronary disease. Now, why is this distinction important, whether or not there's coronary disease present? Because it has management implications. If somebody has coronary disease that's leading to their LV dysfunction, that's when we're going to think about the dual antiplatelet therapies, statin, beta blockers, and ACE inhibitors. And also, in addition to that, it has prognostic implications as well, which is that patients with ischemic cardiomyopathy in general tend to do worse than patients with non-ischemic cardiomyopathy. So is there a role for imaging in trying to help determine ischemic from non-ischemic? And so obviously we have all these different viability testing techniques available. I'll tell you where CMR can be useful in this spectrum. One of the things that we know with CMR is that we're able to directly visualize areas of myocardial damage. So either whether it's due to myocardial infarction or whether it's due to myocardial scarring from a non-ischemic or non-coronary etiology. And one of the distinguishing factors is both of those areas or both of those patterns of damage will lead to hyperenhancement in the heart. But ischemic damage tends to follow coronary artery perfusion territory, and it tends to follow this wavefront phenomenon of ischemic injury, which is that it starts in the subendocardium and then over time gradually progresses out to the epicardium and becomes transmural. So one of the things that it can help us with is if we see a pattern of enhancement that's subendocardial in nature or that's transmural in nature, that makes us think this is an ischemic pattern of enhancement versus enhancement or myocardial injury that you see in the middle of the myocardium, like is shown in this example here of mid-wall striae, that's epicardial, or that's global subendocardial, which obviously would not fit with the coronary artery perfusion territory. So when we see one of these patterns, it's a tip-off that the pattern of injury here is due to a non-ischemic mechanism. Now, and I'll tell you why that's important, because I think looking at wall motion alone is not going to be very helpful in distinguishing ischemic from non-ischemic. And so I'm showing you two example patients here, and both of these have very nice quality cine images, which allow us to look at both EF as well as look for segmental wall motion abnormalities. Now, and I'll tell you that one of these is an ischemic cardiomyopathy and one is a non-ischemic. Looking at the cine images, how many of you think that patient A has ischemic cardiomyopathy with significant CAD? Raise your hand. Okay, a couple people. How many of you think it's patient B that has ischemic cardiomyopathy? Raise your hand. So either a lot of people are sleeping right now, this postprandial lunch somnolence has set in, or what you're telling me is it's hard to tell just by looking at the pattern of wall motion. Now, if I show you the delayed enhancement findings, how many of you think this person here is ischemic cardiomyopathy? Raise your hand. Okay. How many of you think this person here is ischemic cardiomyopathy? Raise your hand. Okay, that's good. Nobody fell for that trap. So obviously, for those of you that are not familiar with this, there's an area of hyperenhancement here that's subendocardial that involves the anterior wall, the septum, and the inferior wall. So again, this fits a coronary artery territory distribution. And in fact, the person on the left, patient A, had diffuse CAD. The patient on the right, who had no hyperenhancement on the CMR, had no evidence of coronary disease. So this is just a different case. Let me skip past this. The first case was more global dysfunction. This is a case with more regional dysfunction. But again, simply looking at the delayed enhancement MRI findings can help you identify the one with ischemic heart disease versus the one without. And in fact, there's now been 4 studies in the literature which have really demonstrated that in the setting of chronic heart failure due to ischemic etiology, there's almost always CAD pattern hyperenhancement present. So in these studies, you're talking about a sensitivity of 98 to 100%. Okay, so and then Dr. Q also touched on this, which is even amongst a non-ischemic, the underlying etiology has very important prognostic implications. So what I'm going to try to do is actually walk you through a variety of different non-ischemic cardiomyopathies and show you how CMR can be useful both from the standpoint of diagnosis, but also from the standpoint of prognosis. So right off the bat, let's talk about RV dysplasia, arrhythmogenic RV cardiomyopathy. And obviously we have these major and minor criteria for defining ARVC. A couple of things to keep in mind is that to make the diagnosis, you need 2 major criteria, or 1 major plus 2 minor, or 4 to 5 minor criteria. So the point is that imaging alone is not going to make the diagnosis of ARVC. Rather, it's a clinical diagnosis that involves EKG, family history, and a variety of other things. But imaging can provide you with major or minor criteria. And what are those criteria? So major criteria, notice both of these start out with this first statement right here, which is regional RV akinesis or dyskinesis or dysynchronous RV contraction. What that means is you got to have some abnormality in wall motion in the right ventricle before you start looking at these other criteria. And so in the past, when people would talk about trying to look for fatty infiltration using T1 weighted techniques and things like that, those are all taken out. And the reason for that is there's too many false positives. The first thing you got to have is abnormal contractility or abnormal motion. And then it meets a major criteria if on top of that you have RV end diastolic volume index, which is greater than 110 for men or greater than 100 for women, or an RV ejection fraction that's less than 40%. If you have any of these along with some abnormality and contraction, you have a major criteria. And then minor criteria basically, again, requires some abnormality and contraction along with dilatation of the RV that's not as significant. So between 100 to 110 milliliters per meter square for men, or between 90 to 100 for women. or an RV ejection fraction of between 40 to 45. All right. Here's another condition. Obviously, I think it's easy for you to tell by looking at the images, and for those of you that are not so good at looking at the images, if you can read, you can obviously tell what the diagnosis is here. It's apical hypertrophic cardiomyopathy, and you can see clearly that there's an area of significant hypertrophy here in the LV apical segments. And in addition to that, when we do our delayed enhancement or late gadolinium enhancement CMR, you oftentimes will find patchy fibrosis in that hypertrophied apex, and occasionally we'll find actually an apical infarct. And again, this is due to this apical trapping, which leads to massively increased pressures within the apical cap. Now, if we look at the more garden variety hypertrophic cardiomyopathy, again, this is an example of somebody who has more asymmetric septal hypertrophy. You can see the septal thickness here was about 2 centimeters. Lateral wall was about 0.8 centimeters. And in these patients as well, in addition to looking at the morphology of the ventricle by cine imaging, if we look at our delayed enhancement MRI findings, you can see that they have areas of hyperenhancement representing myocardial injury. But that these patterns don't really fit with what you would expect from a coronary artery distribution. So it tends to affect the septum at the anterior and inferior RV insertion site, but in fact they can get fibrosis anywhere within the ventricle. There is a relationship of fibrosis to areas that have greater hypertrophy, so the more hypertrophy segments are the ones that tend to have more fibrosis. In addition to that, recent publication in Circulation looked at about 1,500 patients longitudinally and found that in fact the extent of LGE is actually a very important predictor of outcome in these patients. In this graph here, showing the association with sudden cardiac death, showing really that once you get to a scar burden of more than 50% in the setting of hypertrophic cardiomyopathy, your prognosis gets much worse. And then obviously if you have 30% scar, or I'm sorry, 20% or more scar burden, the prognosis was even worse in this cohort. And in fact, what they did is they also looked at a stepwise relationship between patients with HOCM but no LGE, those with less than 10%, 10 to 20, and then greater than 20%, and you can see the incidence of sudden cardiac death progressively increases. And this actually is showing you that not only does the incidence of sudden cardiac death increase, but also the incidence of end-stage HOCM, which again is shown in this dotted line, also increases as well. So that really the extent of hyperenhancement predicts both arrhythmic as well as heart failure death in patients with hypertrophic cardiomyopathy. Let me skip forward now to Takasubu's cardiomyopathy. And again, we can look at these Mayo Clinic criteria for defining Takasubu's, which is basically transient, reversible, regional wall motion abnormalities of the LV, extending beyond that of a single epicardiovascular distribution, the absence of angiographic evidence of flow-limiting coronary disease, new changes on EKG, and then you have to make sure that you exclude other things that could cause this, such as significant head trauma, intracranial bleeding, pheochromocytoma, coronary disease, myocarditis, or HOCM. There's actually a very nice, elegant CMR study which came out a few years ago, which was a multi-center experience looking at a series of patients, close to 240, that presented with Takasubu's, or a suspected Takasubu's. And what they found, interestingly, was that although most patients had the classical apical ballooning pattern, where you see the apical segments being affected, you can, and in their cohort, about 17% of patients had more of a mid-ventricular ballooning pattern, and a small minority, 1%, in fact, had more of a basal inverted ballooning pattern that occurred. And then, interestingly, about a third of the patients, in fact, had biventricular ballooning, which affected the RV as well as the LV. So again, we typically think of it as the classical apical, but in fact, there can be a variety of different manifestations of this. The other thing that they demonstrated in this study also was that these patients really, despite the fact they have significant wall motion abnormalities, they don't have late gadolinium enhancement. And in fact, especially when they're using a strict definition to define LGE more than 5 standard deviations above remote region, there were no patients that had evidence of LGE. So again, the classic finding with Takasubu's is a wall motion abnormality, but the absence of myocardial injury based on LGE fine imaging. And then what they also found in these patients on follow-up is that the EF tended to improve and the LV end diastolic volume tended to get smaller. So these patients demonstrated significant reverse remodeling after a period of time with just medical therapy. Now let's turn to another condition, myocarditis, and I'm going to highlight this publication from over 10 years ago, which looked at a series of 32 patients that presented with clinically suspected myocarditis. They all underwent delayed enhancement MRI, and then what was unique, and the reason why I keep highlighting this study, there's been multiple myocarditis studies since then, but in this study they went and did endomyocardial biopsies in the left ventricle at the site where there was late gadolinium enhancement seen on the CMR scan. And what they found, in fact, was that 90% of the time when they biopsy at the site where there's LGE, they're actually able to demonstrate the presence of active virus. In about 2/3 of the time it was parvovirus, and about 1/4 of the time it was herpes type 6 virus. And again, what you see in these patients is a pattern of enhancement that doesn't fit with the coronary artery distribution. So you can see in this example epicardial enhancement, and the two most common locations were epicardial or mid-myocardial. And there seemed to be some predilection for the parvovirus giving more of the epicardial enhancement and the herpes virus giving more of the mid-myocardial enhancement. And that's been demonstrated in other studies as well. In addition to that, there's been a more recent study which demonstrated that if you take patients with clinically suspected myocarditis and you stratify them based on having evidence of LGE by CMR versus those that do not, there's a significant difference in prognosis in these individuals, both from cardiac death, from all-cause death, from cardiac death, as well as from the standpoint of sudden cardiac death. So again, in these patients with myocarditis, MRI is not only able to help you in establishing the diagnosis, but also can aid in prognosis in these patients as well. Now here's another case. Who's in the echo lab this month? So I'm showing you an outstanding echo here. Very good endocardial border definition, right? So what do you see? So this is just a cine MRI, right? So what do you see? Okay, so you got LVH. Anything else? Okay, so concentric LVH. What else? Or that's it? Okay, so what about the chamber size? Dilated or normal? Normal size. What about EF? Okay. Yeah, the EF here probably is a little low normal. Okay, I think we got 47 or 48%. So low normal LVEF, LV hypertrophy. There's probably actually some RVH as well. Because what's normal RV wall thickness? Yeah, it should be less than 4 millimeters. In this person, it's about 6 or 7 millimeters. So, and again, I wouldn't expect you to know that unless you actually did the measurements. But there's RVH. The other thing is, if you notice, there's this area of high signal outside of the heart here. What is that? Right, it's pericardial effusion. Now, obviously, fat could sometimes present that way as well, but there's subtle differences. And in the interest of time, we'll just say this is a pericardial effusion. So you've got basically pericardial effusion, LVH, RVH. Notice also the atria are enlarged by atrial enlargement, mild LV dysfunction, mild RV dysfunction, increased LV mass. So what's the diagnosis? You sure about that? We're going to write to home, say yes, start. How confident are you in that diagnosis? I mean, and the point I'm making here is that anatomic imaging alone may give you clues, but this could be a patient, maybe I didn't show you the aortic valve, maybe this guy's got severe AS, right? Maybe this guy's a bad hypertensive. I mean, your confidence level in this diagnosis, I think, is not as high. Now, if I show you the late gadolinium enhancement, okay, so you guys are very astute. See, but now I would say, yes, I'm very confident. This pattern of global hyperenhancement, both in the LV, also in the right ventricle, and also, in fact, in the atrial walls as well. This is the classic pathognomonic finding that you see of amyloid heart disease. And then, in fact, that person by biopsy was confirmed to have amyloid. Now, in addition to a diagnosis, having this finding in patients with suspected amyloid or patients with biopsy-proven extracardiac amyloid actually provided very strong prognostic value as well. So those patients in this study, this is a single-center study, patients with known extracardiac amyloid, typically by fat pad biopsy, if they had no LGE in the heart, their survival was very good. If they had any LGE in the heart, all of a sudden the survival was very bad. what you'll notice is that typically what we look at is New York Heart Association class. Well, in fact, in this same cohort, although NYHA class did predict if you had class 2, 3, or 4 symptoms, your prognosis was worse than if you had class 1 symptoms. Notice even the ones with class 1 symptoms had fairly bad prognosis, right? And so the better discriminator here, in fact, turned out to be simply the presence or absence of late gadolinium enhancement. And then that was a single center study. We recently published on a multi-center experience, 3 different sites, again showing the same relationship, which is that if you have hyperenhancement, prognosis is much worse than if you don't have hyperenhancement. And if you have diffuse hyperenhancement, that's kind of the classic finding that you see with amyloid heart disease. Now, let me kind of wrap up here with the last couple slides. What about sarcoid? So obviously, Dr. Q already touched on the fact we've got these clinical criteria that we use, which involves also echo and nuclear findings. And in this study, this was published in 2003 in Circulation, they looked at a cohort of 100 patients with proven extracardiac sarcoidosis and did CMRs on them with contrast. And what they find, a couple of interesting findings. One is the hyperenhancement patterns that you can see in these patients are very variable. You may see subendocardial, transmural, mid-myocardial, epicardial, sometimes affecting the RV, or you may see multiple patchy foci. So the reality is sarcoid can give you many different patterns of enhancement. What they found in this cohort was, in fact, by the standard Japanese Ministry of Health criteria, only about 10 to 12% of this cohort had evidence of cardiac involvement. But by CMR, evidence of hyperenhancement was present in about 25% of patients. Also, how do we typically come across these patients? One is somebody who's known extracardiac sarcoid. They're referred to look for cardiac involvement. The other is oftentimes a patient who just has a cardiomyopathy, and nobody's even thinking about sarcoid. But again, when we see these patterns of non-coronary enhancement, and you couple that to findings of adenopathy within the chest, right? So you can see here there's a lot of paratracheal fullness and adenopathy here, and typically for this study, for cardiomyopathy cases, we'll do a full evaluation through the chest as well. This now gives us a clue that this person may in fact have sarcoid, and so MRI oftentimes is actually the one that's helping to identify sarcoid as the underlying etiology, as well as in patients with known sarcoid, helping to identify if there's cardiac involvement or not. And in this study, what they demonstrated was that if you looked at this group of patients with known extracardiac sarcoid, if there's evidence of myocardial damage by CMR, prognosis was much worse than those patients who did not have evidence of cardiac involvement by CMR. And again, this was looking at a composite endpoint of mortality, symptomatic tachyarrhythmias, or symptomatic bradyarrhythmias requiring therapy. And also demonstrated, in fact, purely from the standpoint of cardiac death, significant difference between those with CMR evidence of involvement in the myocardium versus those without. Okay, so let's get past. Here's another condition. It's not one that we see frequently, Anderson-Fabry disease. And again, this tends to give you this pattern of hyperenhancement, which is in the infralateral wall in the base, and it tends to be kind of mid-myocardial. And again, so if you see that pattern, this is one of the things you want to think about. For patients with non-compaction, CMR can be helpful in trying to identify the ratio of the compacted to the non-compacted myocardium. And in several studies, they've demonstrated that a ratio in diastole of greater than 2.3 provides pretty good discrimination. So again, this is different criteria than what you're used to by echo, where you're doing systolic measurements. There are also some CMR criteria looking at systolic measurements as well. But again, probably the most classic one is looking at a diastolic ratio of 2.3 to 1. Okay. Iron overload cardiomyopathy. So we have a great technique by CMR where we can do this thing called myocardial T2 star measurements. And this basically is a measure that's almost directly related to the amount of iron that's present. And applying this technique, which doesn't require contrast, which is actually just a single breath hold acquisition, you can actually quantify the iron load within the heart, and you could also do the same thing for the iron load within the myocardium. And we have established cutoff values as well, which is that a T2 star value of more than 20 milliseconds almost excludes cardiac iron overload, and a T2 star of less than 10 is diagnostic of cardiac iron overload, and then those values between 10 and 20 are kind of borderline. What's interesting, and again, most of this work with iron assessment was done in England. where this technique was initially developed around the late 1990s. And when they started to employ this technique throughout England, they really were able to demonstrate that for the preceding several decades, there was an increase in the incidence of death due to iron overload, as you can see from the 1970s, the 80s, the 90s. All of a sudden, with the advent of this new technique to help guide therapy, you see a significant reduction in overall mortality, primarily driven by a reduction in the rate of death due to iron overload. So again, this may be a case where imaging is not only helping to make the diagnosis and provide prognosis, but actually may be helping to improve prognosis as well. And then let's wrap up here. In those patients with idiopathic non-ischemic dilated cardiomyopathy, there's also data showing, in fact, that the evidence of having hyperenhancement in these patients is associated with a worse outcome than those patients with idiopathic dilated cardiomyopathy that have no hyperenhancement. This is looking at, in one study, looking at all-cause mortality as well as cardiovascular or transplant-free mortality. Also demonstrates the same thing for sudden cardiac death. And this now is a meta-analysis of about 6 or 7 studies in the literature, which also demonstrated, again, if you have idiopathic cardiomyopathy and you have hyperenhancement, you have evidence of myocardial injury by CMR, you have worse prognosis, both mortality, heart failure hospitalization, as well as sudden cardiac death. And then, so this is kind of a schemata which kind of points out the differing patterns of hyperenhancement that you get with differing forms of myocardial cardiomyopathies. And again, the left-hand side, the ischemic cardiomyopathies, which give you transmural or subendocardial, and then the non-ischemic cardiomyopathies, which can give you midmural, epicardial, RV insertion site, or a global pattern. So again, these patterns are not absolutely diagnostic, aside maybe from amyloid, this global circumferential pattern, but you put all these together, and it can help you in narrowing down a differential diagnosis of what the underlying etiology of somebody's cardiomyopathy is. So to wrap up, what is the role of imaging and specifically CMR? I think it's one, to help you to distinguish HFpEF from HFrEF. Second is to identify whether it's ischemic versus non-ischemic cardiomyopathy. And then the late gadolinium enhancement findings, again, with the administration of gadolinium, I think aid in both diagnosis, prognosis, and potentially even may help to alter prognosis. And so I think I would go back to our cath guys and say, MRI died, don't lie. So thank you for your attention.